In over 20 years reading brain scans, the most rewarding moment is not catching what went wrong. It is seeing a patient who came in for a routine scan, over 60 multiple risk factors, and their brain looks clean. Vessels open, no silent infarcts, no warning signs. And when I ask what they are doing, the answer almost always comes back to the same small number of things done consistently and correctly. A few days ago, I showed you 3 medications that the research links to elevated stroke risk in adults over 60. So today, that is exactly what we are talking about. If you are over 60 or you love someone who is, pay close attention right now. Because stroke is not random. It is largely driven by factors we can actually influence. And the 3 interventions I am going to walk you through today have some of the strongest, most consistent evidence in all of cardiovascular neurology behind them. Today, I am going to show you what actually works, what the research supports, what I see making a real difference in the scans of patients who are doing well, and how to have a specific, productive conversation with your doctor about whether any of these belong in your plan. And the third one on this list is going to be the one that surprises people most, not because it is exotic or expensive, because it is so simple that most people assume it cannot possibly matter that much. It does. Before we get into it, if someone sent you this video, thank them. They did something genuinely useful. And if you find value in what we cover here, share it forward. Stroke is the 5th leading cause of death in the United States and one of the leading causes of long-term disability. And most of that burden is preventable. Someone in your circle needs to hear this. One important reminder before we begin: nothing in this video replaces your doctor's guidance. These are evidence-based interventions worth discussing with your physician, not a prescription you fill based on a YouTube video. The goal is to make you a more informed patient. That is it. All right. Let's talk about the 3 protectors. Protector number 3. And this is the one that comes with the most important asterisk, because it is one of the most misunderstood medications in medicine. You know the scenario. Someone turns 60, reads something online, and starts taking a daily baby aspirin on their own. No conversation with a doctor. Just it protects your heart and brain, right? Everyone does it. Here is what the science actually says, and it is more nuanced than the headlines suggest. Aspirin works by irreversibly inhibiting platelet aggregation. It makes your platelets less sticky, which reduces the risk of the clots that cause ischemic stroke, the kind caused by a blockage, which accounts for roughly 87% of all strokes. For patients who have already had a stroke or a transient ischemic attack, a TIA, sometimes called a mini-stroke, low-dose aspirin as secondary prevention has strong, consistent evidence behind it. A Cochrane review of antiplatelet therapy in this population showed significant reduction in recurrent stroke risk. But here is the asterisk. For people who have never had a stroke or cardiac event, what we call primary prevention, the evidence has shifted considerably in recent years. The ASPRI trial, published in the New England Journal of Medicine in 2018, followed nearly 20,000 healthy adults over 70 and found that daily aspirin did not significantly reduce cardiovascular events and was associated with a higher rate of major bleeding, including hemorrhagic stroke. So the question is not simply, should I take aspirin? The question is, given my specific history, my bleeding risk, my existing medications, and my vascular risk profile, Does aspirin belong in my plan? That is a question worth asking your doctor directly. Bring it up by name. If you have had a prior stroke or TIA, the answer is almost certainly yes, and the dosing and formulation matter. And if you have never had a cardiovascular event, the calculus is more individual, and your doctor should be walking you through it, not leaving you to decide based on what you read online. Protector number 2 is one that many patients over 60 are already taking, but often without fully understanding why it matters for stroke specifically. Statins, atorvastatin, rosuvastatin, simvastatin. Most people know them as cholesterol medications. Lower your LDL, reduce your heart attack risk. That framing is accurate but incomplete. Here is what is happening beyond the cholesterol numbers. Statins have what researchers call pleiotropic effects, meaning they do things in the body well beyond their primary mechanism. They stabilize atherosclerotic plaques in vessel walls. And an unstable plaque, one that is soft and inflamed rather than calcified, is the kind that ruptures, throws a clot into the circulation, and causes a stroke. Statins make those plaques less likely to rupture. They also reduce vascular inflammation, improve endothelial function, and have a mild anticoagulant effect. A meta-analysis published in The Lancet, the Cholesterol Treatment Trialists Collaboration, covering over 170,000 patients, found that each 1 millimole per liter reduction in LDL cholesterol with statin therapy was associated with a 21% reduction in the risk of major vascular events, including stroke. A separate analysis focused specifically on stroke found a significant reduction in ischemic stroke risk across patient populations. For adults over 60 with any meaningful cardiovascular risk factors, hypertension, diabetes, the smoking history, family history, prior vascular events, the evidence for statin therapy is among the strongest in preventive medicine. The conversation to have with your doctor is not simply whether your cholesterol is high. It is, given my overall vascular risk profile, is statin therapy appropriate for me? That question opens a more complete conversation than a cholesterol number alone does. One honest note, statins are not without side effects. Muscle aches are the most commonly reported. Liver enzyme elevation is rare but real. Those conversations belong in the same appointment. The goal is informed decision-making, not reflexive prescription in either direction. And now the one I told you would surprise people, not because it is unknown, because of how dramatically it is underutilized and how consistently patients underestimate it. Blood pressure medication. I know you are expecting something more dramatic, but I want to show you what I see on brain scans, and then I want to show you the numbers, because together they make the case more powerfully than any dramatic framing could. On MRI, we can see something called white matter hyperintensities, small areas of damage in the deep tissue of the brain caused by chronic small vessel disease. They are almost universally driven by one thing: sustained elevated blood pressure. They accumulate silently over years. Patients have no idea they are there, and they are one of the strongest predictors of future stroke, cognitive decline, and vascular dementia that exists on neuroimaging. With the overwhelming majority of patients I see with significant white matter burden have a history of undertreated or untreated hypertension, not catastrophically high blood pressure, just consistently elevated, 145/90 for years, that was managed loosely or not at all. Now the numbers. A landmark meta-analysis published in The Lancet covering over 120,000 patients found that a 10 millimeter of mercury reduction in systolic blood pressure was associated with a 41% reduction in stroke risk. 41%. That is not a modest effect. That is one of the largest risk reductions of any single intervention in all of preventive medicine. The class of medication matters less than the control achieved. ACE inhibitors, ARBs, calcium channel blockers, thiazide diuretics, all have evidence behind them. The PROGRESS trial specifically demonstrated that blood pressure lowering with perindopril-based therapy reduced recurrent stroke risk by 28%, even in patients whose blood pressure was not considered classically hypertensive at baseline. The reason this surprises people is that blood pressure feels invisible. There are no symptoms at 145/90. Nothing hurts. Nothing feels wrong, and so patients deprioritize it. They skip doses. They resist starting medication. They assume that because they feel fine, the risk is theoretical. It is not theoretical. I see the consequence of it on scans every week. The conversation to have with your doctor is direct. What is my target blood pressure given my age and risk factors, and are we actually hitting it consistently? Not just at the appointment, but day to day. Home blood pressure monitoring, taken correctly, tells a more complete story than a single reading in a clinical setting. Ask about that too. Let me bring this together. 3 protectors. Low-dose aspirin. Powerful for the right patient, not appropriate for everyone, and worth a specific conversation about your individual history. Statins. With evidence that extends well beyond cholesterol into plaque stabilization and vascular inflammation that directly reduces stroke risk. And antihypertensive therapy. The single most evidence-supported stroke prevention intervention we have, and the one most consistently undertreated. None of these are exotic. None of them are expensive in their generic forms. All 3 have decades of large-scale trial data behind them. And all 3 require a real conversation with your physician, one where you come in informed and ask specific questions. Here's the question to bring to your next appointment. Given my age, my history, and my current medications, what is my actual stroke risk? And are there evidence-based interventions we should be discussing that we haven't yet? That question changes the appointment. It signals that you are an engaged patient, and engaged patients consistently get better care. Now, if you watched both videos, you have the warning side and the protective side. But there is a third piece that sits between them. The lifestyle interventions that the research shows can reduce stroke risk as powerfully as some medications, and that almost no one is talking about in enough detail. If you want me to cover that, write the word lifestyle in the comments. If enough of you ask, I will record it. And if someone in your life is over 60, send them both videos, the warning and this one. Together, they give a complete picture. That is a genuinely useful thing to put in someone's hands. My name is Dr. Ivy Ellington. I am a radiologist. Subscribe, and I will see you in the next one.